Uh, it might be nice to start with some kind of prayer. Dr. Linda, do you mind giving us a prayer?
Let's pray. King of glory, I bless your name. I worship you. I exalt your holy name. I thank you so much, Father, for this morning. Thank you so much for all the people that have made it into this room and those that are online. I thank you so much for our colleague and friend, Patrick Mwase. I commit him into your hands. I pray that you shall give him the confidence and the patience to tell everybody about the amazing work that he has been doing. May everybody that is in this room and is online be blessed by this session. May it be a landmark session to the glory of your name. In Jesus' name we pray. Amen.
Thanks, Dr. Linda, for that prayer. Colleagues, professors gathered here, the panelists and the supervisors, the audience, you're welcome. You're welcome, and I particularly thank you for making it through the heavy rains. It's not an easy one. That shows the love we have for Patrick. So we are gathered here for the public defense of Mr. Patrick Mwase's dissertation, PhD dissertation, and the dissertation is titled Workplace Violence Against Nurses in Uganda's Public Hospitals, a Phenomenological Study. And we have two wonderful supervisors, both gathered here. That is Professor Julius Chikoma and Professor Paul Vangirana. The DRGT has revised the guidelines, the graduate studies guidelines, and in the revised guidelines, they provide that the defense includes the presentation from the candidate, which takes 30 minutes, not more than 30 minutes, I would say. Then the critical discussant engages with the candidate, which takes up to 60 minutes. And then the examination committee members engage with and ask the candidate questions for about 30 minutes. And then public or the audience also asks questions to the candidate in about 10 minutes. Then after that, the committee dispatches to a closed door discussion to discuss the candidate's performance, after which the committee returns to the gallery and the chairperson reads out the verdict and formally closes the public defense. So that's the procedure that we will be following. My name is Martin Baluku, the Dean School of Psychology, and will be chairing this viva. I would like to introduce the panel that will be assessing the defense. We have Professor Peter Waguma, who is still on the way, making it here. We have Dr. Wilbur Karugahe, who is already here. We have Dr. Benjamin Alpang, who is already here. We have Dr. Lois Kovsinje, she's already here. We have Dr. Paul Nyende, who is also here. And online, we have Associate Professor Joseph Senyonga from Chambogo University. I would also like to introduce the doctoral committee that has been supporting Mr. Mwase throughout the dissertation process. It comprises of 5 members, including Professor Julius Chikoma, the supervisor, Professor Paul Bangrana, also supervisor, Dr. Leon Mataj, Dr. Kajumba Mayanja, and Dr. Kalist Tumwebaze. Unfortunately, he passed away a few years ago. May his soul rest in peace. So having said that, I would like to introduce the critical discussion. Previously, we used to refer to the critical discussant as the opponent. The new graduate guidelines are clear and they stipulate the person as the critical discussant and not opponent. Before that, I would like to welcome Professor Peter Baguma, who is the member of the panel. Welcome, Prof. So our critical discussant today is Professor Stella Nema from the School of Social Sciences. Specifically, Professor Nema is a professor of medical anthropology in the Department of Sociology and Anthropology here at Makerere University. For us who are conversant with her works, we know that she's a prolific researcher in the area of anthropology and sociology, especially medical anthropology. She has initiated and conducted social and behavioral research on young people, sexual reproductive rights and health, malaria, pregnancy, HIV, gender, community participatory studies, and so many other studies. She was also part of the members of staff who were recognized at the beginning of the year at the graduation are those who have excelled in research at Makerere University. So that's the brief profile of Professor Stella Nema, our critical opponent. So at this moment, I would like us to run quickly to the presentation. Before the presentation, the candidate may wish to give some remarks. If he has any, after the remarks, then he will continue to the presentation. Thank you. Over to you, Mr. Mwase.
Thank you, Chair and Dean. Thank you, the panelists, for making it. Thank you, the critical discussant. It has been quite, not easy because of the weather. Thank you, the supervisors, Professor Chikoma and Professor Banjirana. Thank you, members of the public who are present here and those online. And thank you, fellow colleagues. Without much dwelling into that, I would like now to proceed to my presentation. And as I've already been introduced, I'm Patrick Mwase, a PhD candidate presenting okay. So, and I'm presenting on a qualitative study, a topic that is rather sensitive and that is rarely not discussed within public hospitals and within the academia. And that topic is workplace violence against nurses in Uganda's public hospitals. And workplace violence is a common occurrence in public hospitals where nurses are victimized by being threatened and assaulted. According to WHO, it has been indicated that between 8 to 38% of nurses suffer from workplace violence. And in sub-Saharan Africa, it has been highlighted that it is about 54.4% prevalence rate. And it has also been highlighted that in Uganda's public health workplaces, it is a common problem encountered by nurses. And why did I specifically target nurses? Nurses are the most victimized healthcare workers, and they face about 80% of all assault incidences. And this is because they are frontline healthcare workers who are frequently involved with the patients in hospitals. And therefore they encounter violence from patients, families, their visitors, and other healthcare providers. And in undertaking this study, I gave, some historical context of nursing in Uganda. Historically, nursing was established as a female activity, and that kind of perception continues to date. And nurses are the backbone of healthcare delivery, and they constitute about 80% of public healthcare workforce in public hospitals. Nurses in Uganda are confronted with a lot of difficulties that make them susceptible to workplace violence. And in my statement of the problem, I highlighted that workplace violence is a major occupational hazard occurring more often in public hospitals. A high incidence of workplace violence against nurses has been reported to occur in public hospitals, and it has been reported, for example, that verbal abuse is at 63%, physical abuse at 31.6%, and sexual abuse at 8.1%. Numerous studies have investigated the occurrence of workplace violence against healthcare workers, including nurses, but many have not explored to understand why nurses, and particularly females, are targeted and victimized. The purpose of my study is that this qualitative phenomenological study was undertaken to explore an in-depth understanding of workplace violence experiences against nurses in Uganda's public hospitals. And this study was undertaken in line with 4 research questions. I wanted to explore and understand what forms of workplace violence are encountered by nurses in Uganda's public hospitals, what consequences of workplace violence are encountered by nurses in Uganda's public hospitals, and do female nurses encounter more workplace violence than their male counterparts, and why? And lastly, how does the workplace culture of public hospitals in Uganda facilitate violence against nurses generally and females in particular? And the scope of my study was public hospitals, and it was carried out in selected public hospitals, that is Jinja Regional Referral Hospital, Iganga District Hospital, Mbale Regional Referral Hospital, and Bududa District Hospital in Eastern Uganda. And these hospitals, as part of the bigger public hospitals were selected because they serve a bigger population in the surrounding districts and have inadequate infrastructure, are overcrowded and understaffed. And this is the experience that is in public hospitals, even though I focused on those ones. They're also poor equipped and have inadequate medical supplies and low staff at patient ratio. The theoretical and philosophical underpinning of my study is that my study was grounded in the hermeneutic theoretical framework. Hermeneutics offers a framework in which we can understand a specific social phenomenon and phenomena within the historical and sociocultural contexts. And in this case, I undertook this framework to help me have an in-depth understanding of workplace violence against nurses within their historical and sociocultural context. The framework involves re-examination and interpretation of individuals' lived experiences in relation to their sociocultural and historical contexts. And this theoretical framework is rooted in the philosophical ideas of Heidegger and Gadamer. And the key tenets of this framework include language, dialogue, hermeneutic circle, and fusion of horizons. In the case of language, it was used by the participants to be able to frame their workplace violence experiences so that they would be able to disclose them, to the researcher. And in the case of dialogue, as a tenet of the hermeneutic theory, it was used to be able, to interact with the participants, to be able to share their experiences. And in particular, I was able to use it in terms of the interviews, to be able to get information, workplace violence information from the participants. And the hermeneutic circle, as a tenet, that one was used to help me to be able to iteratively get information from participants, but also be able to interpret it, since hermeneutics focuses on interpretation. And therefore, it helped me to move back and forth to be able to examine, re-examine, interpret, and reinterpret participants' information. And then the metaphor of fusion of horizons was used not to be able to interpret the interpreted information of workplace violence from the participants, so that I would be able to get a deep understanding and not only the descriptive aspect of the participants. This study, in terms of the philosophical framework, it is situated in the interpretivist philosophical paradigm. And interpretivism is based on the assumption that reality is subjective and socially constructed from the perspectives of individuals. And it is based on relativist ontology and subjectivist epistemology. The research approach of this study was qualitative, and I undertook a qualitative approach to explore and understand ways individuals perceive and construct their work, the meanings of their workplace violence experiences, and specifically how it occurs within the context of public hospitals. With regard to the research design, this study employed phenomenology as a research design, and specifically hermeneutic phenomenology. Phenomenology as a design specifically looks at lived experiences of individuals, and that's why I undertook it. And in the case of hermeneutic phenomenology, I was interested in not only going with the descriptive information of the participants, but I wanted not to interpret the participants' workplace violence experiences. And therefore, in the process of interpretation, I use double hermeneutic interpretation, where you interpret what has already been interpreted by the participants in terms of their information. And secondly, it is also key because it gives a voice to participants to share their lived experiences within their sociocultural contexts. The target population, I did not target participants between 24 to 59 years working in public hospitals, and those who have experienced workplace violence and are willing to participate in the study. And nurses within this age range were targeted because within Uganda and the public work sector, nurses are recruited into the nursing service at about 24 years of age. Because when you look at the time they're in school, if they start around 18 years, and then they study for 2.5 years, 3 years, then they have internship, it's about 24 years. And I looked at 59 because that is the age in which they retire. But both male and female nurses working in public hospitals were equally targeted for selection. In the case of inclusion, only nurses who reported to have encountered workplace violence and holding permanent working positions in public hospitals with a minimum of 1 year's experience were selected. And both female and male nurses were selected. In terms of exclusion criteria, nurses who reported not having encountered workplace violence had less than 1 year's work experience in a public hospital. Those on leave and nursing students were excluded from this study. The sampling approach, this study employed a purposive sampling strategy to select participants who have lived or experienced workplace violence. And this sampling strategy enabled selection of a homogeneous small sample of participants who acknowledged experiencing workplace violence. And the use of a purposive homogeneous sample enabled me to explore participants' workplace violences in depth. And specifically, since I was looking at workplace violence criterion, I therefore, within the purposive, I went for criterion sampling to ensure that participants who were selected had experienced workplace violence. In terms of sample size, I did select 16 participants in accordance with the guidelines that are given by Cresswell and Noon. It is suggested that a sample size within a range of 5 to 25 participants in a qualitative study is considered to be adequate in achieving the themes and patterns within participants' data, but also it is considered sufficient enough to achieve a saturation. So I arrived at the 16 participants after I had collected data and I realized that I'd achieved theoretical saturation of relevant workplace data from the participants. In total, I had 16 participants, which constituted 10 females and 6 males working in public hospitals. 12 participants were aged between 24 to 40 years, and 4 participants were aged between 47 to 56 years. I collected the data using semi-structured interviews, and these were specifically used to capture participants' voices as they shared their workplace violence stories. But it also facilitated me to describe experiences that were meaningful to them from their own perspectives. In order to have credibility in the data, I translated this data by using key informants interviews. And these were conducted with people who have knowledgeable information, who are knowledgeable and understanding of workplace violence in hospitals, but also who, some of them have probably they were aware of some of the cases of workplace violence that were going on. And the key informants data augmented the participants' workplace violence data that was given. Data analysis was undertaken, and it followed IPA guidelines as suggested by Smith and others. Smith and others are key people in interpretive phenomenology. And it espoused both the emic, the insider, that is the participants, and then the ethic, that is the researcher, where I was the interpretive outsider in trying to interpret the participants' information. And IPA findings are positioned in the participants' experience, language, and context. The analytical framework was conducted in accordance with IPA principles, and it comprised two phases. In phase one, I adopted an analytic, interpretive, outsider position, that is the emic, and this focused on participants' descriptive accounts. So participants who were able to describe and share their workplace violence experiences. And that's why in the analytic framework, I'm calling it an analytic interpretive outsider. I was basing on the participants' descriptive information. And in the second phase, I adopted the analytic interpretive insider position, the ethic. So I had to go a little bit deeper and take a way to understand what were the participants really saying, so that I was able to interpret their workplace violence experiences and the themes and information that they shared. And that is the diagrammatic illustration of the IP analytic framework. And phase one, in the upper blue, water blue color, that is, the analytic interpretive outsider position, where I was looking at descriptive information, where I had to read the transcripts of the participants, generate notes from their transcripts, and then identify emergent themes. And then phase two was the interpretive phase, where I took the ethic approach, where I had now to connect themes from the different participants, and then I was able to move to the other transcripts and then provided a summary of the themes. And those arrows, they are back and forth, which shows the iterative process of analysis, meaning that IPA requires for moving back and forth. The findings of my study, the findings are related to the forms of workplace violence encountered by nurses, the consequences encountered by nurses, and also to explore issues concerning why more females encounter workplace violence than males, and also understanding how the hierarchical workplace culture facilitates violence against nurses. And that visual display highlights the findings of my study in terms of the key themes and the sub-themes. In the middle is the theme, is the phenomenon of workplace violence against nurses, which I was exploring. And then in the water blue color, those are the findings of my study that highlight the themes that lead to workplace violence. And then in the gray color, each theme is connected to the sub-themes as they were identified in the participants' narratives. And one of the themes was reconstruction of violence from society to hospitals, and I was able to capture the voices of the participants, and this is an example of them. One of the participants, and this is participant N1, 53 years of age, who has worked for 15 years in the hospitals, said that because there's violence in society, some people carry it from their homes over to hospitals. And then another participant, N16, highlighted that there's violence in homes. It has now located into hospital wards. A lot of violence occurring in homes has spilled over into hospitals. And that confirms the reconstruction. It occurs in society, in homes, and then it is reproduced and reconstructed in hospitals. And in the case of the forms of violence, my study revealed that verbal, physical, psychological violence and sexual harassment occur in public hospitals. And in the case of sexual harassment, it occurs to both male and female nurses. And those are some of the voices supporting the forms of violence encountered by nurses. Just pick one. Participant N2 said during ward rounds, nurses are abused. One time, I told some attendants to go out, but they resisted. One of them called me a qualified idiot, but I just ignored. Verbal abuse is open and direct. And then there are also others. That highlights psychological violence. Some people we meet think nurses, it is sexual. Some people think nurses are open to any sexual proposals. A patient's visitor approached me at the end of my evening shift. He said each time he met me on the ward, I gave him mixed eye-catching signals. Despite my refusal to listen to him, he rudely continued with his dirty talk. And there are others. Then in the case of psychological violence, as nurses, we are psychologically abused through blackmail. It is common, and they label us as drug thieves. In my case, somebody abused me and labeled me a thief. He said that I steal patients' drugs and sell them. So there are a number of those kind of voices are from the participants. In terms of consequences, the study revealed that there are physical and psychological consequences. For example, nurses encounter headaches, ulceration, loss of appetite, sleep disturbances, and disorders. In the case of psychological consequences, the study revealed stress as one of them, psychological distress, depression, anger, and post-traumatic stress disorder. But interestingly, it also revealed counterproductive work behavior, where nurses engage into behaviors characterized by hostility and negative feeling towards patients and their attendants. And those are voices from participants highlighting some of the consequences. Just to pick one, the second one, the way I was abused, I felt like leaving the job. I became unfriendly and withdrawn from patients and attendants. When you try your level best to attend to patients and instead someone abuses you, you feel demoralized. In line with the research question that explored, do female nurses encounter more workplace violence than male nurses and why? The study findings revealed that this is linked to patriarchal dominancy and sexism, the evaluation of nurses and nursing profession, and gender stereotyping of the nursing profession. In the case of patriarchal dominance and sexism, these are common features that were highlighted by participants, and it is part of hospital culture. And violence against nurses stems from the patriarchal environment that they operate in. And patriarchal dominance and sexism lead to submissiveness and subordination of nurses and their subsequent victimization. And that is one of a participant's voice qualifying patriarchal dominance and sexism. Most of the time in the work world, women are believed to be inferior to men in status. Traditionally, people respect males, which is not the case towards women. When a male nurse is on the ward, they call him a doctor. But for one who is a woman, they just underrate you. Male nurses are highly respected and females not. The fact of being women and considered as inferior to men plays a big role in abuse we face in hospitals. In the case of another aspect that was revealed was the evaluation of nurses and nursing profession. There's a frequent occurrence of devaluation against nurses in hospitals characterized by negative stereotypes. And feminine stereotype image is ascribed to nurses. And this simply stirs up devaluation. Nurses are considered as small people with little competence. They are labeled worthless, academic failures, and low-grade professionals. And that is a voice from participant N9 qualifying the devaluation of nurses. Some people think we are hospital maids who do the nursing care, dressing patients' wounds, give a bedpan, a bed bath. Because nurses do all this work, we are always undervalued. They see us as pet healthcare workers. Tukola gwa kunyiga biwundu bye twasoma tebirina makulu nnyo. Gender stereotyping and of nursing profession. This is it was also highlighted, and it has persisted right from the historical establishment, as I did point out in the context of nursing in Uganda. And gender stereotypes that deem women as less than men put female nurses more at a high risk than their male counterparts. Nursing historically is dominated by women, is negatively stereotyped, and thus it puts females at high risk. And that is a voice from a participant highlighting gender stereotyping. This gender stereotyping of the nursing profession and how it causes workplace violence is linked not to the sex role spillover. Victimization is likely to occur in work environments where sex racial distribution is skewed in either direction. In some cases when there are many, like in the case of professions where men are more and women are few, it can occur. But in this case here, because females outweigh males in nursing, gender stereotyped norms reinforce victimization. So it is not the number that matters, but the gender stereotypes norms spill over in terms of work. And in this case, they are used to victimize nurses. Secondly, the issue of the glass escalator effect. In the case of somebody who would want to know, but the men or the males are also part of the nursing workforce. Why are they not victimized as females? It is because of the glass escalator effect, where most males, when they join nursing, many of them are often pushed upward into higher positions within the nursing field. So you'll find that the male nurses, they upgrade quickly and they end up being the in charges of hospital wards. And therefore they are looked at as big people who cannot be easily victimized. So as a minority in the nursing profession, the glass escalator effect acts as a buffer against their victimization. In the case of workplace culture, the study revealed that this is attributed to low hierarchical position, nurses' frequent availability and contact with the patients, perceived negligence of patients and hostility towards nurses, and perception of violence as a normal occupational hazard. And when you look at those aspects, they are part and parcel of the workplace culture in hospitals, and especially towards nurses. They occupy very low hierarchical positions. It is nurses who are frequently available and in much contact with the patients. When there is blame in terms of negligence, they take the burden, and because of that, many have perceived to be a normal occupational hazard. So in the case of low hierarchical position, nurses occupy most of the low hierarchical position in hospitals, and this promotes subordination and relegation in their hospital work. And because of the low hierarchical position, it has made them to experience professional dominance from doctors, characterized by power inequality, and which is exploited by perpetrators, compelling them to subordinate in cases of victimization. And that is one of a voice from the participant N8, who said, although nurses are many, we have small influence in hospital operations. Even when we complain about the small pay and threaten to strike, they respond with threats to dismiss us. When the doctors threaten to strike, they call for a dialogue to handle their complaints. Nurses are looked at as small hospital workers with a small status. We have taken authority. We have taken authority in whatever we do and get orders from our superiors. This exposes us to individuals who are frustrated within our service delivery. It is one of the reasons we are bullied, especially by patients and attendants. In the case of frequent availability and contact with the patients, the study revealed that nurses are frontline workers, and thus they are frequently available, and that brings them into contact with agitated patients and attendants, which is used as an opportunity to victimize them. So frequent interaction brings them into closer proximity with motivated offenders, which makes them suitable targets of victimization. And that is a voice from a participant who was trying not to confirm that frequent availability and contact. Perception of violence as a normal occupational hazard. My study revealed that violence against nurses is perceived to be a routine and normal experience in nursing work. And many nurses provided voices to that. Due to its frequent occurrence, violence against nurses has become normalized. And thus, nurses consider it to be part and parcel of their job. And because of that perception, it has contributed to low rate of reporting, so that it is not going to be very common for many nurses to talk about it, because after all, it is normal. And perception of violence as a normal occupational hazard, a voice of one of the participants, violence is part of the nursing job. Since we are ever on the ground and always interact with the patients, they easily abuse us. It appears normal for nurses to be mistreated because many people who give care don't appreciate. This is what we go through on a daily basis. I have come to believe that it is a common hazard of nursing job. Enforcement of hospital protocols. This is also part of workplace culture. It is the nurses who enforce. Don't expect a doctor not to be running around. It is the nurses. And therefore, enforcement, thank you, has also been highlighted to be triggering violence outbursts, especially from frustrated patients, visitors, and family members. And that is a voice highlighting enforcement of hospital protocols. Also, shift work is part of workplace culture and lack of guardianship. Nurses work in shifts 24 hours. And victimization is attributed to the limited number of nursing staff that are deployed in these shifts, especially the evening and night shifts. But also in these shifts, and generally in hospitals, there's lack of guardianship, especially in hospital wards. Security is normally provided at the entrance of hospitals. In conclusion, workplace violence engenders counterproductive work behavior that affects nurses' professional commitment and compromises patients' care. It is also a product of patriarchal dominance, sexism, gender stereotyping, and low hierarchical positions prevalent in hospitals. These perpetuate and reinforce a toxic workplace culture of domination and subordination of nurses entrenched in public hospitals. The study demonstrates as a strength the value of hermeneutics in understanding workplace violence phenomenon from a sociocultural lens and how it is shaped by the contexts individuals live in. In line with my study findings, some recommendations were suggested, and I will just highlight a few. In the case of nursing and education, nursing education and training, I recommended that sociocultural competence-based skills, such as assertiveness, should be integrated in the nursing curriculum to cope with a toxic hierarchical work environment linked to patriarchy, sexism, and gender stereotyping. This can empower nurses, especially the females, to have a voice, and also to be able, to guide, the patients. Sometimes some of them who may not actually have respect for them, especially the females. Also, education curriculum reforms by the Ministry of Education and Sports should be undertaken, should be scaled up and implemented to allow nurses to attain their training at a degree level. During my data collection, I found out that nurses at a degree level, yes, they are victimized, but with some kind of respect, not those at a certificate level. And the patients know, and attendants know. That one is a certificate level. Organizational policies, I recommend that there's a need to establish a conducive work environment that fosters and supports a strong ethics-driven work culture to lessen cases of counter-work productive behavior. Advocacy, positive reframing of the nursing image should be undertaken by all stakeholders, such as the Ministry of Health, Ministry of Education, and other, the academia in partnership with the media. So that is the end of my presentation. Thank you for listening to me.
Thanks, Patrick, for the wonderful presentation. However, it's not my role to judge the presentation as wonderful or great. We have better people qualified to do that. So colleagues, join me to welcome Professor Stella Nema, the critical discussant.
Okay. So the chair of this doctoral discussion, because now we have to change. I didn't like the word opponent. It's as if we are in the battle and we are fighting. Yeah, it's good that they managed to change it. So the chair of this doctoral discussion, our candidate, Patrick Mwase, the supervisors of the candidate, the academic panelists, and members of the public, those who are face-to-face, but also those online. And then, of course, all you, the academic colleagues present, protocols observed. Good day to you all. I feel very privileged this morning to serve as a critical discussant for Mr. Patrick Mwase. I'm Professor Nema Stella. I'm a health, medical, social anthropologist from the Department of Sociology and Anthropology. I'm here as a critical discussant, but take note, Mwase, that I'm not a police person looking for faults, but rather to assess the quality of your research and help you grow into a seasoned scholar so that you don't remain as upcoming, okay? I'm here to understand your journey by simply asking thoughtful questions and providing constructive feedback so that we have a meaningful, productive discussion. Okay? Are you comfortable now? Okay. Yeah, I read your book from the first page to page 369. Yes. The annexes, I had also to look at the annexes and see whether they are relevant. The table of content seem not to be done in a conventional way, like where we have like chapter 1, 1.1, 1.11, 1.2. I don't know why you left it like that. Maybe it's a new, a change now. Then the findings, you have very good findings. And I love the way you elaborated on them. That's why I was deleting some of the issues I wanted to ask you. But I'm wondering, why did you lump them into one chapter, findings? It would have been lovely if you had like 2 to 3 chapters, but maybe that's how the graduate school allows. You have a lot, very good findings. The consequences, for instance, of this violence should have been like a chapter on its own because it has very good findings. But that aside, let's go back to what I wanted to say. Why did you choose your title? Workplace violence against nurses in public hospitals. Why not domestic violence against women or men? Or why not violence in private hospitals? Or why not violence not on the nurses, but maybe the higher level cadres? Could you explain that?
I specifically selected the nurses because they play a key role in healthcare service delivery in hospitals. All of us, even including doctors. When they are sick, nurses give them a care. And despite the important role that they play, there are silent voices that the problems they encounter, besides poor pay, is the issue of violence. They are victimized, they are assaulted, they are demeaned, and yet they are available in hospital settings 24 hours. And looking at that as a way to understand and also see how my research can come up with recommendations to support them so that they can be able to provide better healthcare services.
Okay, thanks. And then on your definition of concepts, they are quite well elaborated. But who are the perpetrators? Because, when you read your title, workplace violence, you think it's maybe the medical doctors, the other people who are the administrators are the ones causing the violence. But on the contrary, you also include like the patients, the relatives. So explain to us who are these perpetrators.
Thank you. The perpetrators, in line with my study, are patients in some cases, and the participants highlighted that those patients who are strong enough have victimized some of them in terms of delay to get a service. Then their relatives, where they were calling them as attendants and visitors, especially in line with not complying with the hospital regulations that are put in place. But also, in some cases, though it was toned down, some of the health professions themselves do actually perpetrate this violence against nurses.
Okay, it doesn't come out clearly, so you need to tease out and make it concrete. Because a workplace, it is the hospital. But then when I looked at one of your definitions, I think it was by DiMartino. You remember DiMartino?
Yes.
Who was saying that workplace violence refers to incidents where individuals are abused, threatened, or assaulted in circumstances related to their work, but also including commuting to and from work. So I was wondering, did you encounter any nurse indicating that as they were coming from their residence to the hospital, they were assaulted or they were victimized?
Yes, I did, get some information from participants highlighting that those incidences of violence occur when they are commuting. One of them did actually, highlight that victimization is likely to occur in scenarios where the perpetrators will actually know the routine, since nursing is a routine activity, they monitor the routines of these nurses. So some of them, as they are leaving the hospital and they're out of the wards, they are likely not to be victimized as they are going back home. So I did.
Okay. So you gave examples like variety of specific types of workplace violence.
Yes.
And that was good. And you have, you also had at least some quotes illustrating, typical quotes illustrating what you found out.
Yes.
So to you, of course, there were physical violence, you talked of assault, threats, and also sexual harassment. specifically on sexual harassment, was it more with patients or with the fellow workers, especially the higher level cadres? And before you answer that, was there any form, because it never came out of your study, any form of sexual harassment which is in the form of what we call quid pro quo? You know quid pro quo? You give me, I give you. Quid pro quo. Did you see that form of sexual harassment, especially with the higher cadre health workers?
The findings reveal that sexual harassment occurs more to the females and especially lower level cadre nurses. And in terms of trying to support that, one of the key informants actually did highlight that sexual harassment occurs, especially in cases where nurses are lured in terms of issues of transport, issues of money, though it was highlighted that it is more from the patients and visitors than from the healthcare professionals who hold a high level. But one key informant did actually point out that some healthcare workers at a high level do actually engage into sexual harassment towards nurses.
Yes, I would just imagine the fact that you told us that culture for them being at a lower level.
Yes.
They would, for instance, if there would be training, maybe they would be omitted to go for training. If they don't practice quid pro quo, you give me, I give you. I take you for training, then you give me. So you seem to indicate it wasn't quite often the case.
Yes, I tried to interrogate, but sexual harassment being a very sensitive issue, many of the participants actually shied away, in trying, to share in depth. And the few participants who actually were brave were able not to highlight those cases I've given.
Okay. Then on the literature review, I liked the way you interrogated the literature. It was not more of a descriptive nature. You were trying to understand the existing knowledge, which I saw. You were also trying to identify the gaps, which you alluded to, and then, of course, justifying your research. Is there any other reason why you conducted your literature review, apart from those three areas?
Yeah, one of the reasons I can give, apart from those three, probably was not to appreciate the extent to which there is not so much research in terms of workplace violence that is steeped into the sociocultural perspective in trying to understand issues of victimization against nurses.
Okay. As you know, in essence, the literature review is the foundation of your book. Okay? And it provides the context which you did, justification, and I also loved your theoretical underpinning because it was a springboard to everything else that you did. I love the way you synthesized your literature chapter showing how the hierarchical workplace culture is key in the occurrence of violence in hospitals. I also liked how you revealed how it is perpetuated. But beyond the hierarchical culture that you talk about. Couldn't there be any other factors at play?
Yeah, beyond the hierarchical workplace culture, there are other factors that do facilitate, violence against nurses. And specifically, I was looking at the routine nature of the nursing job that nurses do engage in too. Because of their routine nature, they find themselves that in many instances, they encounter motivated offenders. They do not have adequate guardianship. And secondly, they are also looked at as suitable targets. And especially being that the majority are females, many of them are considered as suitable targets. And also, I did look at another factor is the issue of patriarchy, and therefore nursing being a feminine job, it is looked at with patriarchal lens, especially from members of the society, but also failed healthcare workers. So that could also be a key factor in triggering violence.
Okay. Then on your theoretical and philosophical framework, I was keen to see how you discuss it. The humanitic lens was ably asked because I wanted to see the tenets of this model or this theory, how it works, and I think you did some justice on it. But explain to us the humanitic lens. Explain to us the interpretive philosophical paradigm, and also explain to us the philosophical positioning of your study. That it's this and this and this and this. How do they help each other? How do they inform each other?
As I did, point out, the study is steeped in the hermeneutic theoretical framework. And in terms of the positioning, the study is positioned within social constructivism. And specifically, because I was exploring workplace violence as a social phenomena, and specifically trying to understand it from the participants' social and historical contexts. And in terms of the theoretical perspective, I did not use the hermeneutic theory. And this hermeneutic theory emphasizes issues of interpretation of the lived experiences. And I did not link some of the theories that tailor into the theoretical perspective. That is the routine activity theory, because nursing being a routine job, that simply fitted well into the hermeneutics. And also, I also linked it with the feminist theory. Because nursing is a female-dominated profession characterized by issues of gender stereotyping. There's a lot of professional dominance, especially from the doctors. So I linked those theories into the hermeneutic theory.
Okay. Then coming to those two theories, the rat theory, okay? The rat theory, which is the routine activity theory, and then of course the feminist theory. You are passionate about them, but you seem not to indicate in your book how they complemented each other, the feminist and the rat theory. What were the limitations of each? And maybe did your Ugandan data from the hospitals, the public hospitals, fit well into these constructs of these two theories?
Yes, my data did actually fit well into these two theories, because when you look at the issue of the hierarchical workplace culture, I did point out that nurses do occupy low hierarchical positions, and because of the low hierarchical positions, they are simply, they often find themselves into the routine nature of the job, because people at the low hierarchy, as nurses, are expected, to undertake this work. And secondly, they also highlight the issue of motivated offenders by experiences such as perceived negligence of patients. Nurses are likely not to encounter hostility from some patients, some attendants, and their visitors, because some of them are already agitated, and therefore they are motivated offenders. And they're also considered suitable targets by the nature of the work they do in shifts. And my study highlights that the evening and night shifts are quite risky for them. And some of them are easily targeted in those shifts. And then also, lack of guardianship. It simply shows that many of these nurses, while they are working in the wards, there is inadequate security on the wards, and therefore that is exploited. And secondly, when I look at the feminist theory, the study has highlighted that females are more targeted than males. Issues of patriarchal dominance and sexism are quite prevalent. And it is perceived, based on the participants' information, that domination and control of nurses, especially females, is acceptable. And this has actually resulted into victimization experiences. So they do tailor.
Okay. But I'm not very sure that, these theories that we use is not clearly explained, because in the case of Uganda, in the case of the hospitals you visited, there seemed to be nothing related maybe to a regulation or something of the sort. Okay?
Thank you.
So on the methodology, your design, by the nature of your title, you used the phenomenology design. So I wanted some clarification on this research design. Why did you not use ethnography? Why did you not use case study design? Why didn't you use even grounded theory as a design, given the lens that you are using was the same? Why phenomenology?
Thank you. I specifically selected phenomenology as the design because it is, I considered it appropriate in trying not to focus on the lived experiences and in this case, workplace violence against nurses. And comparatively, when you look at other research designs, a number of researchers have recommended the phenomenological design as suitable to look at, issues concerning lived experiences.
Okay, because there's another psychologist who's doing work on stigma, and stigma is experienced. But this person is using grounded theory, and he's justifying it. So does your justification of using phenomenology, is it okay? You feel that, yes, I used it and that is it. I couldn't use grounded theory or any other because this was the best among the designs.
Yes, I felt it is the best. I'm here to be guided. But looking at the theoretical framework, which is the hermeneutic theoretical framework, I found it suitable for this phenomenological design to tailor, to suit into the phenomenological framework as the design.
Okay, now that you have defended it, what were the limitations of phenomenology design? What did you see as, you can put on a shirt, you've tailored it well, but you find that maybe this arm is too long compared to the other one, the design isn't. So what were some of the limitations of your phenomenology design?
I thank you. One of the limitations of the phenomenological design is the limitation in terms of the sample size of the participants that cannot actually allow the findings to be generalized to other places or other nurses. But secondly, the issue of data collection, as I was collecting data, some of the participants encountered some recall bias of some of the information because some of the experiences have occurred for some time. So in trying not to constitute and construct an articulate narrative was quite a little bit challenging for some of them.
Okay, but I think also the fact that you've told us, I think in the sample selection, that you wanted those who were victims of some sort. Don't you think you could have missed some who didn't want to associate with such kind of, say, like sexual harassment, rape, or anything?
Yes, as a research approach, yeah, it has some of those limitations. I do agree.
So I didn't see anywhere in your book where, like, I would ask, how did you counteract these limitations? So if it isn't there, you might write it because it would be good for other people reading your work to get to know, yes, it's a design, but it's not complete. There are issues that we need to look at when we are using this design. And for your case, you've tested it in the Ugandan population, in the hospital setting, and it has worked, and maybe that's where you found limitations. Okay? Yeah, I had some questions on the methods, but you explained them well, so I don't need to ask you this. Yeah. Validity and reliability. validity, and reliability. These are positivist concepts. You know that. So my question is, how did you ensure validity of your data? How did you ensure reliability of your data? And what is validity equated to in qualitative paradigms? Validity, we equate it with what in qualitative paradigm? Because since this is a positivist concept, and for you, you are an interpretivist. So go ahead and tell us.
So validity generally is equated not to interpretive trustworthiness. And in trying not to look at the interpretive trustworthiness of the findings of the study, I used concepts in qualitative study that equate to validity and reliability in quantitative study. I used aspects such as credibility to ensure that the findings that I generated from this study were credible. And therefore, in undertaking this, I used some measures, notably prolonged engagement. I did spend some time in the research sites to get familiar so that I was able to identify the participants who had actually encountered workplace violence. But secondly, I also did have prolonged engagement with the participants themselves during the interviews. And on average, I was able not to hold interviews with the participants ranging between 50 to 75 minutes. And that is quite an engaging time for a participant. Secondly, I used data triangulation to cross-check some of the areas where the participants were giving me information. Though, since key informants were not the participants, some of the areas that seem not relevant in one way, they didn't actually give them.
Okay. Yeah, you are right that validity as a positive concept is, in qualitative research, it is equated to credibility. And you have rightly indicated how you did it. But apart from that, the right setting and informant is one of the key issues. And indeed, you selected the nurses who had experienced victimization and the multiple approaches, peer review, which was done. Okay, so we are done with validity. What about reliability? It is also a positive concept. How was it in your interpretive lens?
In the case of reliability, I specifically used the methodological approach, that is IPA, in a consistent way, right away from how it guides in terms of data collection and how also it guides in terms of data analysis.
Okay. Is that all?
There are others, but I cannot actually.
Okay, you've attempted, because reliability in qualitative paradigms is dependability. Okay? Interpretation, repeated examination, you talked of the iterative nature, you were going back and forth, so you were trying to make sure that your data is reliable, so it is the dependability. And I think I saw it in your in your book somehow. Okay, thank you. So on ethics, compare the ethical considerations that you suggested in your proposal. Like the issues I saw, I didn't see the proposal, but I was looking at the first chapter and the second, I think, issues of consenting, issues of confidentiality safeguards. So how did it play out when you were at the sites? Did what you wrote in the proposal, was it reflective, or were there any ethical dilemmas that you could have encountered, and how did you maneuver the terrain of studying and investigating violence?
Yes, the ethical guidelines, when I was undertaking my study, I strived to ensure that I adhere to them. Issues of beneficence, issues of maleficence, issues of confidentiality, where actually I had to anonymize the participants. But this study, since it was carried out in hospitals, like one of the challenges I initially encountered was the high expectation of the participants, thinking that since I'm carrying out study in a health workplace where other people have been, so they were expecting some of them, I think, to have a big kind of, token. I call it a token, to them, because a number of people, including professors in public health, have carried out research there. And when they get in there, it is like, they jubilate because they know those who are going to participate will have a big takeaway. So I did encounter some challenge of some of them actually, saying compensation is such small,
How much was it? How much was it?
20,000.
It's not small. It's not small.
Actually, comparatively, I don't want to mention the name of one of the professors. I think he had just carried out research, and they told me 20,000, we are given 50, 1 hour. So I did not encounter that, but I was able not to explain to them and told them that in terms of the research, while Makerere University waived for me, I did actually pick from my pocket to finance this study. And when I shared with some of them, they actually empathized with me.
Okay.
Yeah.
Okay. So now let's go to findings. I think this one I had asked you. Why did you lump the findings in one chapter? You have very interesting findings. I'm a specialist in workplace violence. I wish you had done like 2 chapters or 3 chapters separate, but the way you lump them, we miss a lot. And I think you agree that you had a lot of data, but maybe that's for another time, because we needed a breathing space. When you have like 2 chapters on findings, there's that breathing space where you conclude, you summarize, and then we know what is happening in that chapter. Then it takes us to the next. I won't talk about analysis because I wanted to ask you several questions, but you alluded to them when you were presenting. I liked that thematic analysis and the IPA analysis, and other students, I think we learn from you, because sometimes we usually do not see sometimes when they started, how they started, and what they have. And I also loved the way the pictorial visualization of your themes and how they connect to each other. I also loved the use of quotes, but you may need to reduce some of them, because when I was reading them, some of them were meaning something, were meaning the same, but different wordings. So you need to maybe reduce them so that you might have like 2 to 3 instead of having so many. Those typical ones that you think are illustrative of your description of your narrative of what you are talking about. Okay? Still on findings. I'm almost remaining with 20 minutes. Still on findings, tell us in this auditorium, tell us what were the most significant factors contributing to workplace violence in your study? Because you've told us so many. Just give us like 3 and say, this is it. The second is this. The third is this. The most significant factors contributing to workplace violence in your study.
The most significant among the many include patriarchal dominancy and sexism, which I highlighted is prevalent, and it makes, or it has created a patriarchal work culture in hospitals. Secondly, is gender stereotyping, very prevalent. And then lastly is the low hierarchical positioning of nurses in the hospital hierarchy.
Okay, good. So how did your findings compare to the existing literature on workplace violence?
My findings did compare to others. First, that the available literature is more tailored more to the positivist approach in trying to explain workplace violence. And when I look at mine, it is more tailored not to social cultural explanations of workplace violence. And that simply brings in something that is new in terms of literature.
Okay. So let's go to the comments. I mean to the recommendations. So you gave us the recommendations, and I'm happy. That's why I'm deleting what I wanted to ask you. But at the end of it all, I didn't understand when you said a team-based approach that provides a collaborative working environment with a two-way communication without emphasizing a lot of power and hierarchy should be practiced in doctor-nurse relationship. Yet, you know that the violence you had described to us was not only practiced by the doctor to the nurse because of that hierarchy, but it was also these relatives, the patients. I got surprised, the patients, the relatives, and so many of those. So what is this team-based approach?
Thank you, Professor. When I was looking at the workplace culture in hospitals, there are constituted work guidelines that simply mandate the nurses to be subordinate to the doctors. And that is even known by a number of patients and their attendants. So meaning that much as it is seemingly, a team of healthcare workers working, but their mode of working does not reflect a team where individuals are going to to be seen as playing a role in undertaking their work. And when you look at the hospital culture in Uganda, comparatively to other developed countries, we're operating an approach which is doctor-nurse kind of relationship. The doctor is superior and the nurse is subordinate. And I do suggest that a team-based approach should be integrated into the hospital working culture, where doctors and nurses work as experts in the team. Everybody brings their expertise with their respective team leaders. And in that way, it can help them not only to boost their image, but also create some level of authority in these different areas of expertise. While we look at medicine and nursing, some people think that these are fused disciplines. Each is separate. And therefore, it is on that background, especially when I look at the doctor-nurse-subordinate relationship, which is operated here, that I do put that recommendation.
Okay. So maybe regarding implications and recommendation, I'm suggesting that there are some important questions that you need to reflect on. One of it is, what are the practical implications of your findings for organizations and policymakers, maybe beyond health facilities? Because you did it in health facilities, public health facilities. What are the implications of your studies beyond public health facilities? That is one. And I was also thinking aloud and saying that how can your research contribute to the development of an effective workplace violence prevention program? Okay? I don't want you to answer, but you reflect on those issues, and maybe when you are revising, you would need to see what to add. And then the last one could be, how can your research be applied to different organizational settings and cultural contexts beyond where you went to? That would be good if you can add it into your thesis. You don't need to answer them now because you have the findings, but the applicability. Then as I wind up, sustainable development goals are about to end. The duration, I think, was 2030. Sustainable development goals, they had given them a duration up to 2030. And now we are 2024. So how many years remaining? 6 years. So your study, what SDG is your study informing? What sustainable development goal is your study informing? You know, there are 17 sustainable development goals. So for you, what do you think yours is informing?
Professor, I may not have them on head, but just to contextualize, yes, I've read some of the sustainable goals, but trying, I can locate it in issues concerning, having equitable health rights for all people. Yeah.
Anything else?
No.
I'm also an interpretivist, so I have to ask, anything else? Only that. Okay, yeah, you are right. SDG 3, because it goes towards health for all. workplace violence affects the health and well-being of nurses, but also SDG 5. SDG 5, the ladies here should know. It's gender equity. You remember you used the feminist theory and you were telling us how patriarchy is reinforced. So it also informs SDG 5, which is gender equity, but also SDG 16, violence reduction. So if you can include them in your final write-up, that would be good, especially in the introduction bits. Okay? Then lastly, who is Patrick Mwase after here? I'm going to ask you. Who is Patrick Mwase after you've done your work, you've shared it, it is all in your head? Are you a humanitic phenomenologist? That is one. Are you an interpretivist? That is two. Are you a qualitative researcher? Or are you a workplace-based violence specialist? Who are you now? What should we call you now?
Specifically, all those may tailor, but there's a need not to specialize, especially in the area of academia. I would consider myself to be a hermeneutic researcher, not a criminologist.
Not an interpreter.
Yes, hermeneutics allows no elements of interpretivism. So I embody those into being a hermeneutic researcher who bases arguments and ideas from within the interpretivist framework.
I thought at the end of it all, you would be an expert. Like I'm an expert. I think you've read my work on sexual harassment.
Yes, I did.
Be this violence specialist. So that the WHO calls you are there on their panel, you are there, they want you to do something. Why are you shying away from being? Why are you shying away from being that expert?
I think, Professor, with your support and guidance, I can be there. Thank you.
Okay, so I think Dr. Mwase, thank you for this fruitful discussion. Your confidence and calmness during our discussion were impressive, because I had written quite a lot to ask you, but when you presented, there was no need of asking you, because the kind of theories you delved into and the lenses are quite difficult for some people. But you were not on the defensive. I like that you were not on the defensive, which made for a very productive conversation between me and you. So I can say, congratulations. We can shake hands. Come and we shake hands. Because I said I'm not a policeman. Thank you so much.
Thank you, Professor.
Welcome.
Thank you, Professor Nemastela. I would like to say that that was a calm and composed performance, just like classical music show. So we want to move forward to the next phase, of this process, and that is engaging with the members of the panel. We have 5 of them present. We have Professor Baguma, we have Dr. Paul Nyende, we have Dr. Wilbur Karugahe, Dr. Benjamin Alpang, and Dr. Lois Kovsinje. So we shall probably move in that order. The guidelines give us about 30 minutes for that process. And I've been informed that whenever you are to talk, you have to come to the platform here for purposes of the members who are on Zoom. So I would like us to begin with Professor Baguma. I also understand, as Professor Baguma makes it here, that, you know, some of us came here extremely too early, and some people had not yet had tea. So we're going to have tea as we proceed, but in an orderly manner. So one by one, we cannot have more than one person having at the other table. Thank you.
Thank you very much.
You need to come here for purposes of the people on
Hey.
Zoom.
Is there magic?
There is a witchcraft.
Thank you very much, Dean. Thank you, the presenter. My comments. My comments are somehow backing up what the critical reviewer is saying. I begin with the background or introduction. And in the introduction, there's quite some few things that are missing. You are focusing on a variety of forms and not on one form of sexual harassment. You need to justify this. I hope it is clear.
Can you repeat your question?
Yes, you are focusing on many forms of sexual, of workplace violence. Many forms. Why do you focus on one form instead of choosing one and do it justice? 2, you should include the impact of workplace violence on work performance, on what the nurses are supposed to do. Another concern is the theories about workplace violence. I don't see much theory, specific theories, which will now help you in further chapters. For the interest of time, I will jump some of the comments and go straight to justification of the study. Is not coming out. By the way, before I read the introduction, SDG 3, which is about health, is also important because this workplace violence also affects the health of health workers. Permit me to go to methodology. Methodology is lacking in terms of justification. Every step you take must be justified, especially with qualitative research. I don't see that happening, and the critical reviewer has hinted on it. For example, why do you choose phenomenology? While we have a lot of literature which is quantitative. We already know the percentages, males, females, a lot in quantitative terms about workplace violence, the impacts and so forth. So why do you ignore those and choose to go phenomenological? I hope you are noting down. Some of these you might not answer, but they are aimed at improving your work. And the good thing you talked about, Creswell. Creswell should be your Bible if you want to improve in this area. And the critical reviewer touched it when she was questioning me about your methodology. So read Creswell very much. Repeat it like you repeat the Bible, and you will be okay. I will focus on the idea of instrumentation, which concerns reliability and validity. That is not coming out properly. You talk about triangulation, but do you have data on triangulation? It is not about talking about it, but you want to see it in practical terms in the dissertation. Triangulation results. When we talked about reliability, we want also to see it in practical terms, and to achieve reliability in qualitative research. Things like repeating things to see that, to find out whether you reach the same conclusion or the same result. So there is more about reliability. Then you talk about using homogeneous samples. Is this a strength in qualitative research, or it is a weakness? Because we thought variation would be important to hear various different views about the participants. You also talk about theoretical saturation. When you achieve that saturation, is it still theoretical, or it is practical now? So when you talk about theoretical saturation, I don't understand, because theoretical saturation is an idea that will guide you to stop somewhere. So when you have stopped somewhere, you have achieved it. We talked about, you talked about ethics. Were the participants free from your experience? Were participants free to give you the answers? We want to know that, because this is a sensitive topic. If you ask, did somebody ask you sex? The nurse will not respond quickly. So how did you go about that? To be sure that this nurse is really truthful in telling you what they are telling you. Did some of the nurses break down? Because they might remember that somebody coerced them into some act, and they must start breaking down and crying. Did you get such experiences in the research? And if you did, how did you handle it? Yes, Dr. Nyende, my timekeeper. How many minutes do I have? Okay, let me 2 minutes. Let me quicken up. I won't take your time anymore. So, presentation of results. You know, qualitative research produces a lot of data. So you have to engage in data reduction techniques. A lot of data. And I'm trying to say something which might even increase your data more. This is about data analysis using matrices. You see, in qualitative research, we also have extraneous variables. The other variables that might influence your results. And there is a way we handle those using matrices and cross tabulations so that you can tease out issues to do with socioeconomic status, marital status, religion. Did the Catholic nurses respond the same way like Protestant nurses? So there is rich data that you could come up with, and which helps you in discussing, interpreting, and making recommendations. If you don't use matrices, then you are just giving us things which are amalgamated, which you might not. That's why when you go to recommendations, you find problems because the data has not been analyzed extensively. So tabulation using matrices, and I recommend the use of matrices for subsequent researchers in this area. If you don't use matrices, you are not telling us much. You are just trading on where they have been. And you leave rich data hidden down there that would have given us a lot of implications. Yes. For example, predictors of each form. You handled many forms. Predictors of each form of violence are lacking. Do you mean we should handle the same way we handle sexual harassment and also verbal aggression and so forth? We want to see the different predictors of each form. And that can only be done using matrix analysis. And I think there are softwares which can tease that out. The Atlas T, in vivo, they can come up with some of those cross tabulations that we are talking about. Discussion. Here you didn't discuss for us. You see, qualitative research is the same as quantitative. But the difference is in the approach. But all the other research tenets remain the same. And that is according to Creswell. If you read him very well. So discussion is an integral part of any research effort. Limitations, I don't see limitations in your presentation, at least here today. What were the limitations? People fear qualitative research because that there are limitations. So would have been happy if you also talked about some of the limitations that you faced. The strengths are not enough. Just give us one strength. After 5 years of study, you give us one strength. I think you are being mean. Should have come up with many strengths. So, and this can come out from your other parts of the study. You are only highlighting the methodological strength, but there could be other strength of the study. Apart from the methodological study, the methodological design and approach, there could be other parts of the study where you can gather strength. But I congratulate you on the use of phenomenology, because this to me seems to be an innovative approach. I'm sure some of you have heard about what we call innovation, innovative research. So I congratulate you for using innovative methods in handling this study about workplace violence. But there is an area we call the contribution of the study. I think you need to come out strongly and tell us that after 3 to 5 years, you have gathered many, your study has come up with a lot of strength or contribution to the knowledge, contribution to various areas. What are your contributions? PhD is awarded on the contribution of your study to the existing knowledge. Because when you start talking about stress and what, some of these things are already voiced out. What are your unique contributions of this study that you think we should be proud of? Recommendations, again, we are starved when it comes to recommendations. We get starved because of the way you have analyzed the data. Since you missed out matrices, you don't get rich recommendations. You get limited. So I think you need to read more regarding recommendations. There are some in the recommendations which are not research-based. And you need to base your recommendations on evidence. You talk about, you recommend a policy about ethics-driven, and you don't tell us how. We want usable, finished recommendations. Don't give a recommendation where the Minister of Health is going to think about it. No. Be detailed enough and give us a finished recommendation. Yes, 2 minutes. Yes. So be detailed about recommendations, and let's have short-term, long-term, and medium-term recommendations. Are some of those urgent? And one of the major weaknesses I see in your recommendations is lack of benefits to the participants. This should always be the prime recommendation. Benefits to the participants who spent their time to give you this data. They should be the first beneficiaries. So as a counselor, I'm wondering why you didn't talk about psychosocial interventions for these nurses. Okay? Without forgetting to tell us what is new about your study. Thank you very much.
Remember that we have 30 minutes for all of us, not for each.
Hey, you said each.
It's for all of us. Yeah.
Okay. So let's begin.
Yeah.
So I'm done. You can answer any three if you want.
Can I answer from here?
Yes. Yeah. It's okay.
Thank you. Thank you, Professor, for those insightful comments. You have actually given me many, and as I have mentioned, they are intended to improve my study. So I'll just just pick a few, and the rest I'll have to cross-check. to begin with the, the one which you said as theoretical saturation, I think in terms of research, qualitative research, we normally use saturation as the point at which we are guided in terms of collecting data from the participants, especially if there's redundancy or information repeats itself from other participants. But notably, in saturation, it's not all about redundancy. And therefore, I was trying not to point out theoretical saturation based on the participants' information in terms of the themes and patterns that they provide. So that if the themes and patterns that they're sharing about their experiences showed no repetition, then that is when I stopped engaging with other participants. The issue of did some participants know a breakdown during the interviews? I did point out that it is only after I had conducted the study that some of them told me that violence is a normal experience. So I was just lucky, I can say, that I didn't get any participant who broke down. Nonetheless, I had planned that in cases where any participant did exhibit challenges such as psychological distress and the breakdown, I had contacted already professional counselors where I would refer these people to support them in terms of those kind of challenges. The others, I take them as comments that I can integrate into my work. And some of them, Professor, some of the areas you are raising in the book, but for presentation purposes, the time was so limited that I could not go in depth. Otherwise, I thank you for, the critical discussant actually raised. I'll ensure that I do integrate and look at the SGDs. I think they take my work at a notch higher in terms of what I'm having and make it even more relevant. Thank you.
Thank you very much, and I wish you well.
Thank you very much, Chair. And thank you, Patrick Mwase, for the presentation on this important topic. I have just a few comments in the interest of time. I just really, maybe just one question and others will be comments. How do the theories that you chose speak to one another? I have seen the routine activity theory, RAT, and how does it speak to the feminist theory? It would be important to link the theories and kind of show us how they guide your study in a way that will facilitate conceptual connectedness and make it even more relevant. On the other hand, I want to look at a theory or a model that could be relevant to the study that I don't see you mention. This is Freud's model of workplace violence. Not Freud, but Freud. That's F-R-U-D. So the E isn't there. This is somebody else. F-R-U-D with an E at the end. So Freud's model of workplace violence, not the Sigmund we all know. Yes, so From your presentation, when you look at Freud's model, these ideas are very familiar to you. He identifies 4 factors or 4 levels. And one of those is individual factors, interpersonal factors in workplace violence, organizational factors, where you talk about tolerance for violence, a lack of accountability, the shift work issues, and of course, organizational culture. Okay, those issues. And then the 4th one, societal factors. So we are looking at cultural norms, acceptance and normalization of violence. And you presented all of these issues as you were speaking here. Poverty and poor pay, all those contributing to workplace violence. So I think that this model would be quite helpful or very relevant to the study. It kind of would boost your conceptualization. Right. So we shall follow up on that one. The other comment comes on the literature. At the end of literature, I see large paragraphs in which there is no citation. And it looks more like the researcher's voice, which is okay. We want to listen to the researcher's voice. But this would be more appropriate under summary of your literature or literature gaps. So if you can move that into summary where we listen to the researcher's voice, I think that would be appropriate. And lastly, I was searching through the recommendations. I know Professor has also raised something on recommendations. You seem to have lumped the recommendations under implications. And implications actually are the potential consequences, while the recommendations are specific suggestions. So let us have implications split from the recommendations. The psychosocial interventions, as the professor said, need to be salient because we have the counseling background, and that would really sound very strong in terms of psychology. And others, like developing a zero tolerance policy, developing a reporting system, kind of implementing safety protocols, and the communication that you also mentioned. So look through those recommendations once again, split them from implications so that they are salient, they are clear. Thank you very much. Those are the comments I have.
Thank you, Dr. Nyende, for that insightful comments. I will take an opportunity to look at Freud's model, but specifically as a brief response, I did specifically go for the rat because nursing is a routine activity. And nursing being a routine activity, I did select it as being suitable to guide me to understand this. But I do appreciate that there could be very good information that would enrich my work. And also, thank you, even the critical discussant did raise it in terms of the implications that will make my work much richer. So thank you, I'll do that.
Let's move to Dr. Wilbur.
Thank you so much, Dean, and thank you so much, Patrick, for the good presentation. I will not go through all the sections of your dissertation because I had a chance to review it. So I will just ask 3 questions because the rest of the comments were put in my report. Now, looking at your topic, that reads that work violence against nurses in Uganda in public hospitals. Now, I have a concern because you collected the data from participants in Eastern Uganda. Is that correct? So why are you giving an impression that you collected the data from all the regions in Uganda, yet this data was collected from one region? Maybe you could respond to that first.
Thank you. With regards not to collecting data, this being a qualitative study, I actually did not need to collect data from all the participants. And secondly, why did I say Uganda? Considering the topic workplace violence, it simply focuses more on the workplace culture in hospitals. And looking at nurses, this workplace culture cuts across all public hospitals. And these nurses do encounter similar challenge, similar problems. And therefore, what drove me to say Uganda is because of that. But specifically, I do highlight where I was able to select these participants who were able to help me appreciate this specific workplace culture.
So you're basing it basically on the findings from one region to make an assumption that the nurses in other regions will be going through the same. Is that right? Yeah, because I mean, it would be very important to indicate that this study was done in Eastern Uganda so that the reader knows that that's where you collected data. But the impression you get by looking at the title is that data was collected throughout the regions of Uganda. But I think you have made it clear that you're basing on the findings from Eastern Uganda to generalize. Then my other question is about the nurses in private hospitals. Because you're making an assertion that the nurses in public hospitals are more vulnerable to work violence, workplace violence. So did you also look at the data to get the statistics of the nurses who work in private hospitals?
Thank you. In terms of issues concerning private hospitals, I did actually, based on the literature that was guiding me, that workplace violence is prevalent in public hospitals and not in private hospitals. And therefore, I needed to be guided by evidence and not just simply assuming. Secondly, I know private hospitals, there may be also cases of violence, but that probably would be an alternative study in line with this one.
I would actually instead recommend that you include this information in your problem statement to kind of bring out the comparison. And that would then provide a clear rationale why you are actually picking on public hospitals instead of private hospitals. And at the moment, that information is missing in your problem statement. Now, my last one is about your contribution to the psychology fraternity. What would you consider as your major contribution to the psychology fraternity? or if you were given a chance to give us that one major contribution of your study to the counseling psychology fraternity, what would that be?
One of the major contributions that I can cite to the psychology fraternity is from this study is to provide a benchmark into which workplace counseling services should be stepped up and expanded within hospitals. Because when you look at what is happening, psychologists are very limited in hospitals, and it is only in the recent past that clinical psychologists have been integrated into the hospital work. So I think that will be my major contribution.
Okay. Thank you. And then the other comment I wanted to make is about the limitation section. I think Professor talked about that. You need to make sure that you have a limitation section in your work to make sure that the issues that you are not able to address are included in that section. But besides that, it is a well-written piece and a such innovative topic. Huh? And I want to congratulate you and thank you very much.
Thank you, Dr. Arugahe.
Good afternoon, everybody. Yeah, protocol observed. Patrick, I think I can now call you Dr. Patrick. I want to sincerely congratulate you upon the immense work you have done on this particular topic. I had the pleasure of reading through it, and reading through it, I know how much you put into it. That's why I'm congratulating you. If you had been a lazy person, I'm sure you wouldn't have finished it by now. Yeah. Now, in the interest of time, I just want to a few things that you clarify for us. And as I was reading your work, I was interested in the part of the conclusion. Remember, you are dealing with hermeneutics, the science.
And in some cases, the participants were not able to articulate some of those issues I was articulating them. For example, I did talk about issues of sexism, issues of gender stereotyping, and the language is that the context that they were trying not to share their views was from a descriptive point of view, and therefore had not to interpret what they had interpreted in sharing. But specifically, it was more linked to the socio-cultural contexts in which they live, so that the interpretation should fit into that.
Yeah, thank you. Now that you have mentioned social cultural context, that was the next issue I wanted some clarification on. Because if I see one of your research questions, it is looking at how does the workplace culture of public hospitals in Uganda facilitate violence against nurses generally. But also in your background, you talked a lot about social cultural context. So I'm wondering, were these the same concept? That's workplace culture of public hospitals and social cultural context. Because I would want to think that social cultural context would refer to the culture where these workers in the hospitals come from and having influence on the violence they experience in the hospital. So like these people are from Eastern Uganda. I don't know which is the dominant social cultural background they come from. But given that, the hospitals also, each hospital, I'm sure, has its own workplace culture, which I think should be differentiated. But when I try to read, it seems this research question seems to be suggesting social cultural context. And we did not find anywhere where you try to describe the social cultural context of these nurses who were involved in the study. So it becomes very difficult to understand whether it is their ethnic social cultural context which influenced the violence in hospital, because they are talking of people at home are violent, so they also transfer it to the hospital. Or is it the workplace culture in the hospital which was the one causing the violence? Thank you.
Thank you. In this context, when we look at the element of sociocultural context, we're not looking at the ethnic or regional kind of, culture. We are looking broadly, because this is what, the framework dictates. We are looking at it broadly in terms of, for example, the work culture as a social cultural context of the nurses where they work, but also the work culture as a social cultural context also is linked to the larger society context in which people live. So there is a link, between the two. And here specifically we're not looking at the group where these people work, and that is what the hermeneutic theoretical framework does focus on. And secondly, it is one of those areas of sociocultural interrogation in terms of understanding social phenomena. There are a number of them. It is one of them. Yeah.
I think maybe somewhere in the background you could find a sentence or two to clarify that. That would be quite good to know. And then lastly, again about theories. Many people have talked about it. But as I was reading through it, your work, especially the discussion part, I expected you to bring in a lot about the theories to see whether they agree with your findings or disagree, or actually help shed light on your findings. Particularly the feminist theories, when you look at some of the workplace violence being caused by patriarchal dominance and gender inequality, sexism. I think these ones they fall within the feminist realm. So I thought it would feature very prominently in trying to discuss your finding with that. But it seems to be silent. Maybe if some changes have been made, that would be very good. Yeah, and the same thing also. Yes, I've talked already about the social culture. Okay. Yeah, there's also that theory of gender oppression, which is similar to the feminist theory. Is a form of feminist theory as well. Could have come in. So I don't know. Maybe you could revise and see how you can bring in some of those gender oppression theories. Yeah, it also comes in there. Otherwise, I think time has gone. People are hungry again after tea. So let me stop here. Thank you for the great work, and welcome to the work of a doctor waiting for you there in the school.
Thank you for those good comments. I'll explore and see how I can integrate it into my work with the guidance of my supervisors. Thank you.
Thank you, Dr. Benjamin Halpanga. Over to Dr. Lois Cobbs.
I think it's already afternoon. Good afternoon, our most important guest, Patrick Mwase. When you are the last panelist to comment, you just have to summarize other people's comments. One of the disadvantages or limitations of phenomenology is bias. personally, I had a certain bias towards nurses. Little did I know that in this issue of violence, they are also victims. I thought they were the villains, using the lens of a patient or caretaker. So I didn't know that patients subject nurses to violence. So it's an interesting study. When it comes to your methodology chapter, you told us your paradigm. But when I looked at the book, the physical book, you did not give it a specific section that you start from the paradigm and then you proceed to the approach. I don't know why you did it like that, but I just had a few days to look at your book. I could be wrong, but I think it needs its section and then comparison to other paradigms. Then at the end of the day, you conclude by telling us why you preferred interpretivism. Yes, the word is long. It would be interesting to know from you that after today, who are those around 5 literature citations or sources that you will never forget and why? We usually have them. Somebody will tell you, I have Bandura, I have who, I have who. So who are the most, at least 3 literature sources that really showed up as the most critical in your study and why? You can think about that. When I looked at your objectives, because you could have objectives, for example, what are the forms of violence that the nurses are subjected to, the effects and so on. But then, so what? I know you dealt with the interventions at the end, but why was it not important for you to put that as an objective so that you collect suggestions from respondents and other stakeholders on how violence against nurses can be mitigated? It's just a thought. Why nurses? I know you talked about it, but did you do a comparison of nurses vis-a-vis other professions for you to say, I'm zeroing on nurses? I know you're a clinical psychologist. You had to look for a population within your area, but even within that area, are they the only victims of violence that you could have studied compared to other professions? Even lecturers experience violence in many forms. And as a clinical psychologist, what do you consider to be the most important mitigation strategy for violence as a clinical Your counseling? Somebody misled me. I said, is Simon clinical or counseling? Okay, from a counseling point of view, there is that is Og, then there is Simon. Oh, yes, okay. So as a counseling psychologist, what do you consider to be the most important mitigation strategy for violence against nurses in Uganda? And what are the end results if this is not taken care of? And maybe that is where we get an overflow, that there must be a possibility that a nurse that is experiencing violence might end up projecting that violence on the patients, on the caretakers, because us who got the triage, we think the nurses are violent. Maybe the beginning is violence at their own workplace. And then I don't know if I had listened properly. Was there any peculiar form of violence that the male nurses specifically gave you or presented to you that you think is unique to them as the male gender compared to the female nurses who are the majority? Thank you. Do you feel you want to answer some? Yes.
Just to know, you talked about the most critical authors in the literature. Yes, I can off-head, highlight. And since you talked about literature, there is even methodological literature. I think One of them is Smith and others who are very critical in explaining the hermeneutic phenomenological approach. That when you look at their work, it is not only trying not to explain the methodology, but even they cross over in trying not to help understand how it is important as a sociocultural perspective. Secondly, in terms of the workplace violence, not so much has been written. I can do really appreciate Wandera and others, and also the work of, I've forgotten the author, but Professor Nema is one of them. There's a research paper actually that made me to appreciate issues concerning health issues within the Uganda's health systems. Newman. Yeah. Yeah. The others are issues that I can cross-check first with my supervisors, but also the methodological approach sometimes dictates some of the things we do. I know there are many proposals that are really good and may be integrated, but I need to consult experts to guide me and tell me this is okay, this is not okay. Because otherwise, I might end up having an entire mixture of each and everything. Thank you.
Thank you, dear panelists, for engaging with the candidate. We now have about 10 minutes or less for the public to also engage the candidate, and we are talking about the public that's present here and the public online. I will also take an opportunity to make my own comment or question. So I will go first. When it came to when you are interacting with the critical reader or discussant about the forms of violence and also who the perpetrators are, you were a little bit hesitant to confirm whether the doctors and other people in the workplace are actually the major perpetrators. So I would like to know, in this case, if, for example, resulting from this work, you get an opportunity from, say, MACRIF or any other funding agency to, to design an innovative intervention to help the nurses in the workplace, which is that one category that actually you target, the category of perpetrators that you target, and why? Then during last week, we had 2 events in the university where one thing emerged as affecting this university at the moment. We had the budget conference on Friday morning, and the university secretary emphasized that it looks like Makerere University employees are very angry at the moment. The same issue was emphasized at the Choose Management, at the Choose Leaders workshop on the same day. So I'm wondering, looking at these things that happen in the workplace and, creating a toxic workplace, do you think you have gained some knowledge here that can help us to deal with this anger of employees in the university? Then 3, would you think it is possible in the future to also look at how this violence suffered by the nurses, probably quantitatively, explains the emotional labor that we see the nurses offering? You go to a hospital, you'll find some nurses who will be very happy offering the service, and they look genuinely happy. But then you find some nurses, they will treat you as if they are treating a co-wife. Then we have another comment from an online participant. That is Prosi Solome. She says, thank you, Mr. Mwase and all panelists. Indeed, nurses who experience psychological torture or workplace bullying may suffer severe consequences affecting their well-being, job performance, and overall quality of life, like decreased job satisfaction, productivity, absenteeism or tardiness, increased risk of medication errors, decreased patient satisfaction, and consideration of leaving the profession. Dr. Mataji.
Yeah, thank you, Dean. I have two observations. One, I would like the presenter to include in his future research recommendations about violence against female doctors, not nurses. Maybe that could be studied, that could be very interesting. And then, secondly, the connection between the experience of nurses, the violence, and the work performance, as Professor Okba highlighted. How does it affect the performance of nurses? The doctoral committee member, I think we emphasized that at one point. Thank you.
Thank you very much. I would like to raise one on the title. As one of the panelists mentioned, you talk of Uganda, and then you argue that because you were basing on your findings to generalize, and I find it insufficient. Uganda having 4 regions, and you having conducted a study in one region, that is Eastern region, I would personally find it, which better word should I use? Unfair to say that because Eastern is like this, all the 3 regions are like that. Had it been 2 regions, perhaps we would have, I would have agreed that we can base on the findings to generalize. So it reminds me one time when it was at my MA, I had also stated the same. I was looking at billboards in Uganda. However, I collected data from the central, and it was contested that I can't say Uganda when actually I'm focusing on the central. Would you find it bad to specify that you are handling Eastern region instead of the whole country? Thank you.
Thank you, Chair, and congratulations, Patrick, for the journey so far. In your analysis, could you have discovered that there could be indicators of perceived workplace violence, just perceived? And also, when you were presenting the justification for your study in the background, you mentioned so many challenges regarding to the nursing profession and practice in Uganda. And one of them was poor pay. You called it poor pay. Could you talk about when you collected data, whether it was before or after their salaries were specifically had been increased, because now a certificate nurse is earning not less than 2 million shillings, Ugandan shillings. Are they still dissatisfied with that pay? And can we rightly call it poor? And finally, violence, your presentation, surprisingly, just like what Dr. Kobusinje notes, was more from the general public, especially patients, seemingly being violent to the nurses. as a comment and part of your conclusion, I don't know whether I just missed it. Would you want to repeat whether mainly the public was seen, according to your evaluation and analysis, as the most perpetrators, or the nurse to nurse, or female to female, or other workplace categories of staff like the medical officers, call them doctors, or administrators versus the nurses? Thank you so much.
Thanks, Patrick, and for this especially. I don't know that I didn't get this, and I heard Professor Nema asking it, and asking because, and this is purely me, the silly me. So when we talk of violence, we're talking of unmet needs. If we go psychology and Rosenberg and nonviolent communication, so it's unmet needs, and I see you work within gender perspectives, which is quite interesting because nursing has shifted over time. And my question about this, especially with regard to gender, is if we talk of violence as unmet needs, is that how you're seeing it at the workplace? And if that's not how you're seeing it, then what's your definition of workplace violence? Because continually I kept asking myself the question, what is workplace violence, and who determines that workplace violence, and who is the victim, who is the perpetrator, who defines all those people? Because the moment we are not clear about that, then some of us may start thinking, okay, maybe I'm the one now confused about this. But I think it is something that I really looked forward to seeing, and I kept waiting and I did not see it. And I don't know if you defined it, maybe I missed that. Just asking.
Yeah, I think you can answer some of those. There are a few of the comments and questions online, but probably.
Just not to start with, I'll start with Dr. Tibasima's question. Of course, in this context, we are not looking at workplace violence as unmet needs, but we are looking at it as incidents encountered by nurses, characterized by threats, assaults during their work, and also during commuting to their work. And I did, yes, as I did not flash it, but I did talk about it as one of those. So I'm looking at it from that context. The issue of perceived workplace violence from Dr. Balikowa, in my case, I was not looking at perceived. I was specifically looking at individuals who had encountered the workplace violence. And in this case, after I had been cleared by the ethics committee, I had not to identify the respective public hospitals basing on social networks, because in research, social networks can also provide you how to get some of this, or to navigate some of these areas of research. And when I got at the hospitals, and after I'd been cleared by the hospitals, I engaged the hospital in charges first, because the protocol in hospitals is actually so rigorous that there are steps that you must follow. And when I engaged the in charges, shared with them about my research, and that actually gave them, a way to think about it, and also shared that had been cleared by at the respective hospital administrators. And thereafter, I was able to engage with them again because it was iterative to ensure that I would get into contact with with the nurses themselves. And after building rapport, after I'd been authorized, I established rapport with the nurses and shared with them the intention of my study. And informed them, first, to provide consent, but secondly, to ensure that only nurses who had encountered workplace violence were to be selected. And I left and also gave them my contact. And then I went back. So there were a series of familiarization. It was not a one-day's engagement. But in summary, I ended up selecting only nurses who had encountered workplace violence. And even before interview, I had to probe. So if anybody would simply talk about perception of violence, those ones were immediately dropped. And the issue of region, as I said, if you look at the nursing culture, it is the same in hospitals. And in qualitative research, specifically, we are not looking at numbers, to justify, some of these issues in research, even small numbers, and we go into depth. And based on that, if I simply say then Eastern Uganda, then that simply now is going to lead me into another study. And it can be even a study about a hospital. Then somebody will say, leader hospital. So those can be other studies that can be specifically interrogated. And with the experts, we looked at this, and they were justified that since I was using a phenomenological study, hermeneutic, social-cultural aspect in the hospital, that would actually be fit to leave it that way. Thank you. The issue of perpetrators. Are doctors perpetrators? As I've already mentioned, if you're going to carry out research, I'm not saying only in hospitals, but even other places. But the hospital culture is quite, very sensitive. And therefore, if you're simply going to examine, to look at research from healthcare providers at another hierarchy, that will require another protocol. So it's not just a matter of getting there and you say doctors. Otherwise, they can easily close you out. But nonetheless, in my interviewing and interaction with the participants and key informants, they did actually mention, not specifically the doctors, they did mention that other healthcare workers were also victimizing the nurses. And specifically, when you are interrogated about some of the other areas, they were talking about verbal issues, But when you look at issues of sexual harassment, it is a sensitive area. And I have proposed that a research study should be undertaken to explore sexual harassment within public hospitals in Uganda. The others, Dr. Mataji has raised to provide the connection of workplace violence and performance. Yes, I did talk about it under counterproduct behavior. I'll improve to make my work much better. Lois did talk about, no, I think I answered that one. The issue of how can you deal with violence in the university. I think we are looking at different work cultures. The university is academia. The other one is an issue of health. There may be issues that marry. So probably that can be an area for further interrogation. Thank you.
Thank you. We have some further observations and questions online. So we shall quickly peruse through them. We have Elijah, who is asking sexual harassment for men. I'm waiting on to hear about that. And since probably you had some male nurses, maybe you can highlight something. What are the experiences of the male nurses? We have Gerard Sereko asking, why pose the question of whether women face more violence, yet even earlier literature suggests similar? How exactly did you measure this question? Wouldn't have been better to examine prevalence instead to get a sense of gender that gets most affected? At the look of things, it seems like the study was more inclined towards women, yet it had a gender aspect in investigation of the two genders. Who is more affected? Wouldn't it have been better to hear from the male nurses too? Then we have Elizabeth. Look at this professional idiot. Okay. How do they say it in their local language? Remember, language was used as a unit of analysis. In a year one, I am a year one master's in counseling psychology student. I've been listening. Okay. Well, this one is just a comment, trying to appreciate. Sometimes clients, because they are psychologically stressed, they tend to be violent. I already read this. Okay. They're saying the question about SDG was a tough question. Yeah. Thanks everyone. Is the violence of nurses directed by the old mode of doctor command, mode of practice? Question here: are nurses only female? If not, was the violence gendered? That's say males and female nurses. Who suffers violence more? What are the likely immediate interventions specifically addressing stereotyping? And then an important one comes in here. What policy work has the research thought about to address the burden? I think this one is suggesting that you should write a policy brief from your work. Kindly let Doctor discuss some of the challenges he encountered and how he managed them. Then we have Sheila Virunji. That was a powerful defense, Patrick, and I applaud our University of Makerere for offering space for us to participate. I just wanted to provide information that actually the Eastern region had no single clinical psychologist when I checked early this year. Therefore, agreeing with the discussant on the issue of scarcity of the service. If there are any, then should be engaging privately. Experiences in most regions are same to Eastern region. This is based on my personal experience while participating in some of the countrywide studies. I think it's trying to add to your response. I was also interested in hearing more other underlying factors relatedly, like socio-economic factors that seemingly make them have perceived violence, which they exhibit while attending to clients, probably trying to emphasize Dr. Barikwa's question about perceived violence. Otherwise, Patrick has made us proud, and we are looking forward to tapping into his knowledge. Then we have Eria. The discussion is really insightful, and like Professor Nema, some questions were already answered. If you listen to, there is recent paper on Uganda's health sector and specifically gender roles. The issue of male stroke female nurses is still affected by gender role constructed biases that is inherent in collectivistic cultures like Uganda, and it's providing a useful link there. I hope there is a way to get it. Farouk, is there a way to get this link? I think he has already also sent it because he's saying I've provided a paper to Dr. Mwase in the recording. Okay. Did the researcher interrogate the nurses, how the nurses try to counter or cope with the violence? Thanks, so motivational and powerful presentation. A lot to learn for as we treat the same path of academic excellence. That's it. Probably maybe you can respond to some of them. And as you respond, also Anne wants to ask something, but you can first respond to that. That will be the last one. Okay, this is the last one, then you can just speak.
Thank you very much, Patrick. Mine is not necessarily a question, but I think from a few responses or feedback, they have been wondering why the study should be in Uganda other than the Eastern Uganda. But if I've got you well in your responses, I think maybe in your background, it should come out clear that the culture, this workplace violence culture in public hospitals is more or less the same. So if it comes out clear in your background, then now it will not be questioned by any reader, since now you are only giving us experiences, lived experiences from the Eastern perspective. I thought maybe you would find, when you think about it, I think it can somehow work, because you were trying to explain to us this culture, it cuts across, and indeed, yes. So if it clearly comes out as a social culture norm, then you are only explaining it using the humanistic, the humatic perspective, that one from the Eastern perspective. Then too, I think it would be pertinent if, rightly so, from the literature and from your findings, the female gendered experiences, they rank highest. And I think that's why the feeling is, what is new. So I am thinking that if you try to highlight clearly a few of those peculiar male gendered experiences, it would add something to the literature. Those are the two observations I wanted to make. Thank you.
Thank you. I think there are quite many. I hope I'll be able not to get some of these and I look at them in detail. But just not to highlight a few, like there's a question about sexual harassment for males. Actually, in my presentation, I did actually highlight that sexual harassment against males also occurs, though from the participants, it is encountered more by the females. And I did actually cite a voice from one of the participants, their voices. And in their case, they were talking about issues of how especially the female attendants want to hook them in terms of support during their stay in hospitals. And some of them actually dress in an odd way that is provocative. So I have some of that. The issues of gender, I think this was by Nsereko. I think there's a perception when we look at workplace violence against nurses, the perception that comes to many people is that nursing, these are women. I must actually point out that they are men. But by the nature of the profession, women are the biggest, or they are the majority. And therefore, when I say violence against nurses and then look at females, I'm trying to use a gendered lens to be able to explain this violence, even when it is probably seen as obvious some people that women are actually encountering it. And I'm trying not to link it into a socio-cultural perspective to understand, because much of the work that is there, as I did point out, it is from the quantitative approach, the positivist approach, giving us figures and whatever. And therefore, I'm trying not to bring out, using the gendered lenses, also to understand that, yes, it happens to the females, but why? And I did point out in the statement of the problem that a number of studies have actually investigated this area of workplace violence, but many have not taken a step further to explain why nurses, and particularly females, but also in terms of bringing the socio-cultural, explanations of why this occurs. Thank you, the one who raised about the issue of policy research issues. I think during my study, one of the things he did was to be trained into a policy, how to write a policy brief. And this is something that even my supervisors have encouraged. And I did write out one, which was submitted to DRGT. But I think there are many policy issues that can come from this research. So thank you very much. Then the one who talked about interpretation of language, I was talking about how participants can frame their experiences from their own perspectives, and that tailors to the tenet of the hermeneutic theoretical framework in terms of language. And in my interpretation, when somebody calls, a participant was called as a professional idiot, how did I interpret this? My interpretation would be linked to issues of devaluation of the nurse.
Excuse me, Chair. Which language did you use in the research?
I did use English.
So how does that tap into cultural issues? There is a good comment.
Cultural issues.
Yeah, I don't think you should brush it away.
I can't.
We are talking about language, and language is related to culture.
In this context,
you need to think about it. Proceed.
Professor, I need you to clarify a little bit. When we talk about language, we are talking about not the native language that people use in the context of hermeneutic phenomenological framework. We are talking about the language that participants use not to express, communicate, and frame their experiences. Yeah. So I think others, I can get them from here and look at them more into detail.
Okay, thank you, Patrick. I think you have been a wonderful candidate this morning. I just imagine all these questions from all these panelists, and you have remained calm and composed. You haven't even taken a cup of tea, but that's part of the battle. I want to point out that you have had a very big audience online. At one point, we had over 70 participants. So that shows how people are interested in your work. So we go to the next phase of the process, and that is the panelists are supposed to have a closed session to discuss the presentation and come up with a verdict. Of course, procedurally, we are supposed to be the ones to move out, but unfortunately, we don't have so many rooms around. So I'm going to ask the physical audience not to go far, but remain within the corridor. We shall call you in less than 5 minutes' time. The online audience, please don't go away. Remain with us. The most important part of the process is the verdict, and you have to hear that. Thank you. I hope the online audience is back with us. Again, I want to thank everybody who has been part of this process as we come towards the end. In this last segment, we are going to read out the verdict, and then we shall have a word from the candidate and probably a closing remark from one of the supervisors. So I want to go straight to the verdict. The panel has discussed the presentation and all the related issues that we need to pay attention to. And I'm glad to inform you that the panel has found your dissertation worthy of the award of the PhD of Makerere University. Congratulations. So as I've said, our job is done. Now over to you. You can have a word for the members, and then one of your supervisors can have a word before we close.
Let me talk while standing. Thank you very much. First and foremost, I'll begin by thanking my supervisors, Professor Chikoma and Professor Banjirana. Professor Chikoma is not here, but I'll go to Professor Banjirana. There's one thing I like about him. He's a straight talker. He will tell you what he thinks, whether you like it or not. Thank you. When he got a letter and I approached him as my supervisor, he told me, "You want me to be your supervisor? I hope you'll be serious, but I know you are serious." And he told me, "Don't let us down. Thank you for your support. Thank you for your guidance and for the encouragement." Those words continuously ring into my mind. Professor Chikoma is not here. Probably I'll talk when he comes back briefly. But in absentia, I would like to thank him for having allowed to be my supervisor, because he would have also opted out and said no. But most importantly, as the social cultural class, for having mentored us into appreciating other aspects of research, especially the sociocultural approach that is not so familiar within psychology as a discipline. So I would like to thank Professor Chikoma. Like Professor Banjirana, Professor Chikoma is also very straight. And their approach is they challenge you. So I have benefited in terms of learning from challenges. They say, "No, go and read that." And when I started this research, I was immersed into a state of confusion. Should I go quanti? Should I go mixed? And I recollect Professor Chikoma just laughed at me and told me, "This is your research. Tread your waters. Wherever you will go, I will support you." Thank you for allowing to supervise me. Thank you for the support. And I can say the product I've presented today is a result of standing on the two giants in terms of research in their different expertise. Professor Banjirana is from the College of Medicine and Health Sciences, and also Professor Chikoma in the College of Choose. Secondly, I'd like to thank the doctoral committee members, Dr. Mataji, Dr. Mayanja, and in absentia, because actually he passed on, Dr. Kalist. The initial conceptualization of this work, they did actually play a key role. I'd also like to thank the staff in the School of Psychology. They have been pushing. You must, everybody, Dr. Karugahe, Dr. Nyende, Dr. Lipanga, Dr. Balikowa, my colleagues, Kamis Musanje, Dr. Nantamu. I also like, to thank Dr. Nantamu. He also gave me a challenge. He told me, you want to do this work? First explore. And he told me a PhD is a learning process. And even after the PhD, you continue to learn. I would like to thank the Dean, Dr. Baluku, who has steered to ensure that I move at this level. Thank you for your support, encouragement, and even input. Quite often when you would get across literature concerning nurses, I would just simply check my email and I would find some literature I dropped there. I thank you and continue even doing it to other candidates. I would like to thank Professor Baguma for his mentorship, not only at this level, but even right away. He challenged me and he said, I'm about to retire. But as I retire, I must see you get a PhD. Thank you very much for that support that we continue to get from you and the mentorship.
Asante.
I'd like also to thank the support and administrative staff. I'd like to thank our registrar, Hajat Bahia. I would like to thank Joyce Hatemere, all the time, providing all the information that is required. I would call Joyce as the unsung hero. Many of us have been able to get information that is very vital to us. Please, Joyce, thank you very much. I'd like to thank the critical discussant, Professor Stella Nema, a very prolific researcher and somebody who is interested also in mentoring and nurturing the young people. I do appreciate the areas and issues that you've raised to help my research be a better one. And also tap into her experience so that I can grow better into being a better academic in the area of research. Since she's a medical social anthropologist. Thank you very much for engaging me and for raising the critical areas that can make this a piece of work a better one. I'd like to thank the public, those who have been physical and those online, that without them, probably this defense would actually not be as meaningful as it is today. The weather has been quite bad, and others have other challenges, being a Monday, but they've given me their time. I cannot take it for granted. Finally, I'd like to appreciate all the comments and questions that have been raised, and looking forward to guidance to produce this piece and make it a better one. Thank you very much.
Okay, thank you. I think we also thank Farouk and all the...
You actually, it was an oversight. Thank you, Farouk. Farouk is one of the unsung heroes that we rely on. Last week, he quickly sent a message to me, I don't see this and this, please go and do this and this. Farouk, thank you. And all of us who go through this process, you are one of the notable presenters around in all the presentations. And thank you for the support and the calmness each time we disturb you. Because when I came in here, I actually disturbed him and he said, no, relax. We shall be able not to go through it. Thank you very much.
Okay, thank you for the nice words. I did not mention, but the panel recommended that you make sure you work on the comments within less than 1 month, preferably 2 weeks, so that we are ready for graduation. Okay, we can have a word from one of the supervisors, and then we call it a day.
Thank you very much, Mr. Dean, and once again, good afternoon, everybody. And thank you for being here. I'm also very happy that we've got to this point. As we always say, when you're a supervisor and your student is defending, in some way you are also defending, or at least the eyes are on you. And thank you very much, Patrick, for successfully defending and in the way you've done it. I know that the last 2 days we have been trying to go through your work in preparation for this defense. And I must say I'm actually very impressed and also proud of you. Why do I say this? Is that when we met, it was Saturday, to prepare for this. Patrick came with, I think, close to 80 slides. And then I said, we're in trouble. Because being also at the Directorate of Research and Graduate Training, I'm aware that there have been some changes in the expectations of how long the defenses should be. And I know that the policy provides for 30 minutes. And here he is with 80 slides. And each slide was full of things. I said, how are we going to make it? But I'm glad that our back and forth with him has produced a product and a performance that I had not seen in a long time from Patrick. So congratulations once again. But of course, this effort and the product is a product of more than Patrick and myself and Paul. It's a product of very many people who have contributed in different ways. Some of it is not even, you can't quantify it or you can't even point to it. But somehow, there are ways that Patrick has been supported by the school. And it has contributed to, his positive development. And today that we are now looking at a new brand of Patrick, I thank everyone who has been supportive of him. He also marks, I think, the second last person that was among the group that we created a social cultural class. You will be aware, those who have been in the recent past listening to PhDs from psychology, they have been mentioning the word social culture, social culture. It is something that came as a result of my involvement with the PhD students in the school, the time when I was dean, where I thought that in order for us to be able to, as our students and ourselves as researchers, to be able to understand the context in which we are carrying out these studies, we should be intentional theoretically to really study the context, apart from just the topic, and use, theories that come with the literature that we are familiar with. Why don't we be intentional in digging a little bit deeply in what issues that the context adds to the way we understand the things we are studying. So the rest have graduated, and I think there is only one who was in that class that is remaining. So I'm happy that the whole group is actually, I think we're having only one. And your completion has also inspired, I'm sure, the remaining one. In the not so far future, we will also see that one. So for the rest of the panelists and the wider administration of the school, thank you very much for what you have done. And please continue to support others. And what else can I say? I can only say that now I can have another space to replace Patrick. Now I'm one supervisor less, so I have more space. Thank you very much.
Yeah, thank you, Prof. Yeah, can also greet.
Just a few words. Thank you, Patrick. This has been quite an honor supervising you. As a supervisor, you get proud when you see your students shining. So I'm quite proud of your performance. It was quite amazing. This research also was a learning experience for me. I was learning many things from reading your literature, your methods, because I'm not very good at qualitative methods. So it was also a challenge for me to read your work and supervise you. So it was, I think we benefited from each other's expertise. So it was a pleasure. I came on board a little bit late. So I want to thank Professor Chikoma for having done a very good job, because by the time I came, you had really made so much progress. So it was quite an honor to be part of the team. Thank you very much. And thank everybody from psychology.
Okay, thank you to the supervisors. Where I come from, where I did my PhD, they call the supervisors doctoral fathers and doctoral mothers. And what we know is that fatherhood and motherhood does not end with marriage. You continue fathering even after the person has gotten married. So what I'm saying is, I think you still have the responsibility to mentor him to turn in this wonderful book into publications, either as a book or as several publications, but also beyond. Having said that, and there being no lunch, I think we can say we enjoy the day. Thank you, everyone. Oh, yes. Over to you, Farouk, for the picture.